A route of infection, it could be either bloodstream bacteremia and even septicemia, or ascending infection from urethra. Okay? يبقى bacteremia or ascending infection. The pathogens like most common زي ما قلنا قبل كده Escherichia. The second is staph. The third is a Klebsiella. Fourth, Proteus. And any nosocomial bacteria. Okay? يعني like as you see most common causes of negative bacteria. Escherichia, Klebsiella, Proteus. Okay? Also nosocomial bacteria اللي هي most commonly in hospital acquired infections. So and commonly in Enterobacters or Pseudomonas. Enterobacter or Pseudomonas. Viruses, cytomegalovirus. In spite it is إن هو the weakest viral but has a widest spread for infections. Okay, so Escherichia coli like a bacterial organism, cytomegalovirus like a viral organism is the most common, and lastly is a Candidial or fungal organism is the most common organisms affecting our urinary tract system. Like what about risk factors or predisposing factors? Not all human can be affected by these organisms except if they have a structural or functional abnormality, or decreased host defense, or also varying between the male and female because of hormonal changes, postmenopausal hormones and so on. So structure abnormalities ان يكون عنده مثلا a patient have a repeated history of stone formations, have a vesicular reflux, anatomical disturbance or anatomical abnormalities, have a senile enlarged prostate or any cause for prostatism or prostate enlarged, have bladder wall infections mostly by bilharziasis like Egypt. Any abnormalities affecting structure or even function affecting your tract predispose for repeated infections. Also, females are more prone for repeated urinary tract infections. Anatomically, she have a short urethra, so any lesions or any infection at any site in gynecological system will be reflected to her urethra and urinary tract system. The changeable between the hormones in perineum period and postpartum also affecting, because estrogen is very important for the integrity of the epithelial structures of female urinary tract system. Okay, so the hormonal changes will lead to urinary status, urinary stasis, vesicular reflux, and increased risk of urinary tract infections. Any surgery, any drug induced, any diseases decreases host defense like diabetes. So many multiple, even iatrogenic bicatheter associated urinary tract infections, and this is common in our hospitals. So the predisposing factors is very important to induce urinary tract infection, specifically if it is repeated. According للclassification احنا بنقسم we divide according to, first of all according anatomically في upper urinary tract infections which include the kidneys and the ureters, and these causes pyelonephritis. في lower urinary tract infections. This is comprises البلادر, الurethra and the prostate, developing cystitis, urethritis and prostatitis. According to predisposing factors, complicated urinary tract infections and uncomplicated urinary tract infections. Complicated urinary tract infections, those infections caused by gram-negative organisms. Gram-negative organisms or fungal infection. Okay, this is all causes for complicated. Uncomplicated mostly like catheter-induced, like change في host defense, whatever the cause, like في females most commonly it is uncomplicated unless it have a complicated infections in her gynecological system. So the complicated urinary tract infections mainly depends on male sex, old ages, presence of any urinary tract abnormalities like stones, obstruction, reflux, history of previous surgery in urinary tract, stone passer or stone formers, okay, taking any immune suppression drugs or having a severe comorbidities like diabetes, chronic use of steroids, have a hospital-acquired infection from any sites, bacteremia and even septicemia, and history of chronic kidney diseases or even just renal impairment. These factors leading to mostly ending by complicated urinary tract infection. And accordingly, a source of infection, either nosocomial or community acquired. These are classifications. By classification, it is classified according anatomically, upper and lower, according to severity of infection, complicated and non-complicated, according to an indwelling source of infection, community acquired or nosocomial urinary tract infection. First, we discuss lower urinary tract infections. Most common form is cystitis. Prostatitis and the urethritis is a topic for urological systems. But here we have no everything about cystitis syndrome. Presentingly, cystitis, the patient will be presented by suprapubic pain with severe dysuria and interrupted urine flow, with burning micturition, increased frequency, with or without hematuria. The patient with cystitis syndrome will be presented by suprapubic pain due to difficulty in micturition, with increased frequency without complete voiding. Need to return back to toilet to evacuate. Necessity to evacuate, has a sense of in-evacuation.
That's what's causing the
frequency. Interrupted stream, not complete forward stream. Interrupted stream. Severe dysuria and pain during micturiation, with burning micturiation, and urgency with or without hematuria. Most of cases, severe cases, have a hematuria, because we have said before it is a gram-negative, mostly gram-negative organisms. However, in upper urinary tract infections, where it is affecting post-kidneys and ureters, so the patient will have a fever. It is a closed system. A fever, flank, loin pain, with constitutional symptoms like fatigue, malaise, nausea, and vomiting. Toxemia, because of toxemia. Okay, يبقى patient have a fever, loin pain and tenderness when examination with frank constitutional symptoms, nausea, vomiting and so on. Plus symptoms if it is an retrograde infections from lower symptoms of lower urinary tract symptoms.
Okay.
Okay?
يعني السيمتوم بتاعت اللور يورينري تراكت موجوده بس اذا
لو السبب if the cause for upper urinary tract system pyelonephritis is from down upward, you must have a symptoms of lower urinary tract system.
It will be a combination of both symptoms.
No, it may be upper urinary tract complications for lower urinary tract.
Okay.
It could be, but if it is caused by bacteremia, septicemia, not necessary to have lower urinary tract system. If you have children will have an irritability, poor feeding, failure to thrive, and even in elderly it can reach to delirium and acute confusion with severe of septicemia or bacteremia, accordingly the degree of infection and the severity of infection. دي جملة كده احنا بنقولها ان اللور urinary tract يعني بيبقى usually not necessitate to have a fever, but upper urinary tract must have a fever. Okay? Because upper urinary tract, kidneys closed system, ureters closed system, but urinary bladder have a direct pathway, so cannot bacteremia ان هي تسبب cause a fever. Diagnosis, urine analysis. Diagnosis mainly depends on urine analysis, either by dipstick or microscopic examination. This is the method for collections, يعني for interesting, for reading. But you must to know urethral catheterization is contraindicated. If you have a lower urinary tract infection, avoid urethral catheterization, because we can do a spread for infection by upgrading the infection to upper urinary tract system. The diagnostic criteria for UTI: presence of biuria, pus cells or white blood cells of more than 5 per high power feet, normally from 0 to less than 4, from contamination or contagious. Okay? But if it is more than 5 to 10, it is your patient have urinary tract infection. Bacteriuria means bacteria of more than 10 في 6 multiply 6، يعني تقريبا بنقول 160 100,000.
10 million.
اوكي 10 multiply 6 organism per minute.
up to power 6 ولا by 6؟
10 أس 6.
10 6 160 160 10 times 6 64
Hello?
10 times 6
في المحاضرة أخلص وأكمل. organism per even 1 milli. تتقال ازاي 10 أس 6؟
up to power 6 10 up to power 6.
Other criteria in urine analysis you have to look for stress, leukocytes stress positive. Okay, these enzymes produced by pus cells or white blood cells, and positive nitrates. Positive nitrates in dipstick and positive nitrate in blood. You can ask for nitrate level in serum. Okay, يبقى positive nitrate in blood and this positive nitrate in urine, and this is the most common diagnosis for gram-negative organisms, specifically Escherichia coli. And urease, like other finding, leukocyte casts plus or minus hematuria with mild to moderate proteinuria. خلاص؟ يبقى اليوريا تراكت انفكشن نشخصه ازاي؟ urine analysis. By dipstick we can say mild proteinuria, mild hematuria, urine having pus cells of more than 5 white blood cells per high power field, microscopic examination, positive erythrase, urease, positive erythrase, positive nitrates. Okay? The cultures is mandatory. The cultures is mandatory. When, if you have a significant biuria or significant bacteriuria of more than colony 5 أس 5 of 5, this confirm a diagnosis in cultures. And so it will help you the type of organisms. So when we do urine cultures, any case with complicated urinary tract infection, all patients above 65 years old and patients on antibiotics. With suspected lower urinary tract infection, امتى اطلب؟ لو انا عندي lower urinary tract infection, if there is a persistent symptoms of more than 1 week, if it is recurrent lower urinary tract infection, no diagnostic urine analysis, and we have suspicion for pyelonephritis. Okay, this is the indication for. امتى اعمل when imaging ultrasonography or an even multi-slice CT or retrograde cystography, when if you have persistent symptoms of more than 3 days in spite of good and appropriate antibiotic therapy, recurrent symptomatology within the treatment under effective treatment, suspected obstruction, and you have a secondary severe illness like septicemia or bacteremia elsewhere. If there is no response, despite good diagnosis, good culture, good treatment, you must do radiological or any imaging you need. If you have a patient in ICUs or complicated by hospital-acquired infection, whatever the cause, like severe septicemia, you must do radiological imaging to diagnose. So it's first of choice CT, multi-slice CT without contrast. Why without contrast? Because most of patients we have a renal impairment. If we do with contrast, we can go for acute kidney injury. So it is better ان احنا نعمل في الاول, it is better اننا to diagnose without contrast. Then you can do ultrasonic, X-ray, and so on. Any modalities for radiology you can use. Sometimes we have a severe type of cystitis syndrome named and a painful bladder syndrome or interstitial cystitis. Interstitial cystitis. It is a non-infectious cystitis of unknown etiology. You have a fever of unknown etiology? This is like patient presenting by manifestation of cystitis but without unknown etiology. You have to do everything for anything. Negative, 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 negative. Okay? So it is called an cystitis of unknown etiology. Of unknown etiology. Presenting mainly or debilitating by persistent suprapubic pain and tenderness. Pain and tenderness. And this pain will be relieved only by voiding and worsening by filling of bladder by urine every now and then. Once you get a urine in bladder, you have a pain. Once you evacuate out urine, you have relieved. Okay? The urine analysis and the cultures must be to rule out the bacterial origin of infection, but mostly have no explanation. Some theories stated that it may be due to genital abnormalities, genitourinary abnormalities like vesiculouteric reflux and so on. Okay, or even interstitial infections deep to interstitial cells, not epithelial or endothelial. Okay, it affecting the interstitial wall, the wall in interstitial pattern. So it need a biopsy to confirm the diagnosis. We don't know, we don't roll out by it is a recurrent but relieved self-limiting. But الرخمة أو بنقول عليها worsening إن هي recurrent specifically in children, specifically in women. So the pregnancy, the vesiculouteric reflux, the anatomical any abnormalities, urogenital abnormalities, it could be leading cause for interstitial cystitis with the breast immunity or host defense. If you have a host defense immune compromised for any cause, we have this type of syndrome. So the management mainly behavioral modification, mainly behavioral. Avoid coffee, excessive coffee and tea, bladder training, ask your patient to go toilet every now and then, not let him to full bladder with urine to avoid its irritation. Okay? The trials, pain management, okay, can be relieve some pain, but have no definite role. And intravesical lidocaine or anesthesia will help. But mainly it is a behavioral modification.
Okay.
The most common topic we see specifically in females pregnant to females asymptomatic bacteriuria. The patient have an 10 colony or 6, but no symptoms of urinary tract infection. ما بيشتكيش خالص. No complaint. Specifically those with immune compromised patients, diabetic on corticosteroid, on any immunosuppressive post-transplant, okay, or have pregnancy, old age, no organism will be definitely on cultures or even in urine analysis will be debated. Most those are an gram-negative like Escherichia coli, but elsewhere. So it is more common in females. Genital organs could be transmitted from genital organs and could be presented unless it is a severe on Escherichia cause. And also the second cause is a fungal infection. Fungal infection. Treatment recommended in pregnant women must have a treatment to avoid any spread of infections. And if the patient is a healthy, good and well, not pregnant, elderly, have an diabetes and so on, you have no need to intervention يعني. ايه الحاجات اللي احنا بنستخدمها؟ mainly beta lactam antibiotics, trimethoprim sulfa with follow up late culture. Okay? The uncomplicated the same You can do an phosphomycin single dose, but necessary to do renal function because it is contraindicated in CKD. Nitrofuran for 7 days also must be avoided in patient with renal insufficiency. Trimesoprene sulfur, okay, can be used, but in patients have any drug resistance before, or hypersensitivity reactions, or renal impairment must be avoided. Generally supportive treatment, fluid plenary for fluids, empirical treatment will uncomplicated, and urinary analgesics like antihistaminics could be painful, could be penifia. The second line is fluoroquinolones and or cephalosporin. The last choice is a penicillin. What about the complications of persistent urinary tract infection? Specifically complicated urinary tract infection. Generally, spread of infection, urosepsis, pyelonephritis, perinephric abscess, emphysematous pyelonephritis, prostatitis or orchitis, urethral strictures, increased preterm labor and birth, preeclampsia and hypertension in pregnant women. So, a complicated urinary tract infection must be treated well. Must be treated well. Prevention, avoid repeated catheterization when the patient have need, you have no need, and bladder avoiding training course with increased fluids and good genital hygiene. Okay? يبقى good genital hygiene, bladder training courses to become mostly void any urine collected. Every hour, ask your patient to go toilet every hour. Not let him to precipitate his urine. Okay? To avoid the irritation, to avoid the secondary infection, and increase the fluid intake. The second important topic is pyelonephritis. Pyelonephritis. Pyelonephritis means inflammation or infection of renal pelvis and renal parenchyma. Mainly ascending bacterial infection from bladder. Okay? يبقى pyelonephritis, kidneys and the ureter. Infection of renal pelvis and parenchyma. الكدني نفسها والrenal pelvis up to down even urethritis. The most common cause for pyelonephritis is ascending infection, retrograde ascending infection from the bladder. The most common organisms or pathogens is gram-negative. The first is Escherichia coli, Pseudomonas, Klebsiella, Proteus, كل ده بيعمل. The second rarely is gram-positive, Staph وstrep Enterococcus fecalis. In immune compromised patient, fungal infection. In immune compromised is fungal infection. Also, the pyelonephritis is classified complicated or non-complicated. And this is important to estimate أو to adjust according للcultures والseverity which type of antibiotic I have need to treat. Complicated pyelonephritis in the severe condition ending by emphysematous pyelonephritis, then end-stage renal failure. Retro or peri-renal abscesses and could be septicemia and death. So, complicated nephritis, pyelonephritis is very dangerous. Very dangerous. زي ما اتفقنا, is an upper urinary tract infection, so you must have a fever, toxemia, chills, nausea, vomiting, pain, dysuria, and flank pain with flank tenderness. Costophrenic angle is tender. It could be bilateral. When the patient is very bad, it could be bilateral, but mostly it is unilateral. One kidney is affected. But in severe cases, if the patient's luck is not lucky, we have a bilateral pyelonephritis, usually unilateral. So we have all symptoms of cystitis because we said before that upgrade infection. Urine analysis with microscopic examination is very important, and very important to look for white blood cell casts. Okay? White blood cell cast. Urine culture is very important, okay, to perform bacteremia, how much of more than 1 oocyte or less. Also, we do a blood culture. يبقى urine culture, blood culture. والبلاد culture repeated 2 sets. فاصل بينهم 1 week. 1 sample, and then after 1 week we do another sample. يبقى urine analysis, microscopic urine analysis, look for white blood cell cast. Blood cultures twice. Followed by 1 week. The second, urine culture is mandatory, okay, and the other inflammatory criteria, blood inflammatory criteria, like CRP, ESR, CBC for leukocytosis, and urinary pregnancy test. لو أنا patient is suspected to have pregnancy, to avoid any infection for baby or not. الاتريال ماتريوتيك بيبتايد، يعني ده مش على طول يعني بتعمل. Imaging, abdominal ultrasonic CT with or without contrast if there is no renal impairment. MRI, okay. What is suspected we can see in imaging? Either stone, hydronephrosis, perinephric abscesses, emphysematous pyelonephritis. يبقى radiology oral imaging to exclude those: perinephric abscess, emphysematous pyelonephritis, hydronephrosis, يعني back pressure. Hydronephrosis means enlarged kidneys due to back pressure, and تتحول إلى pyelonephrosis, converting to pyelonephrosis, and stones formation.
في diurnal variation في البلاد كلتشر في البلاد سامبل ولا لا؟
ايه؟
في البلاد سامبل لما بناخد بلاد سامبل، هل مثلا لو خدنا الاولانيه الصبح ناخد الثانيه الصبح برضه ولا ممكن؟
لا، هي المورنينج سامبل. هي morning sample. Urine analysis must be the second morning sample.
البلاد؟
لا البلاد لا اليورين لازم the second morning sample. لا blood has no timing. Vesico-ureteric reflux, we may need avoiding cystoscopy and urodynamic test if you have to exclude a neurogenic bladder. اوكي؟ يعني الحاجات دي ممكن بنعملها. التريتمنت بقى. If you have an uncomplicated pyelonephritis, just fever, dysuria, pain, patient is healthy well, you can give him an empirical antibiotic before the
results come up.
results of cultures, like cibroquininols for 5 to 7 days, or sulfa for 2 weeks. Okay? Consider a single initial dose of broad spectrum empirical intravenous antibiotic. It is preferable ان انا بدي single dose IV في الاول empirically, then continue by oral if it is not complicated. But if it is complicated, with supportive care طبعا, plenty of fluids, analgesia, and avoid dehydration. But complicated, you must to look before. Risk factors for infections by MRSA, complicated by multi-drug resistant bacteria, like age, hospitalized or not, before taking an antibiotic recently or not, have an indwelling urinary tract devices, cystoscopy, catheters, have an abnormality in genitourinary system or not, or travel to area have high rates of infections. The most common drugs used according to culture. The complicated pyelonephritis is culture. And before culture results, we can give him quininols and cephalosporin. Quininols and cephalosporin. For severely ill, with or without risk factors, ندي ميرولين, penicillin, broad spectrum penicillin, okay, and cephalosporin if there is septicemia or presence of risk factors. With a duration must be not less than 2 weeks, والantibiotic according للculture sensitivity في البلاد and urine, identify طبعا and treat the primary cause. Additionally, if there is a source of infection or obstruction or complications like abscess, consider urology system to evacuate. A patient going rapidly to acute kidney injury must be dialyzed. A patient have a septic shock must be considered in ICU observation. This is the scheme, illustrates the summary for management of pyelonephritis for reading, and this is an important. Complications mainly urosepsis and urosepsis leading for pyonephrosis ending by nephrectomy. Urosepsis is severe complications ending by pyonephrosis and need for surgical removal of the kidney. The second is emphysematous pyelonephritis. The sac of kidney will confirm or transform it into multiple sacs of air, deform it and lyse it into, transform it into multiple sacs having an air. So also need a rapid removal. And the third one is perinephric abscesses and renal abscesses. What's need for urgent evacuation by urology or urologist to avoid septicemia and peritonitis and pelvic congestion and pelvic infections. The last one is renal papillary necrosis. All these ending by end-stage renal failure. So, complicated pyelonephritis must be treated urgently. Urgently. This is pictures for emphysematous pyelonephritis. زي ما شايفين ان هي sacs of air. بيحصل destruction للكورتيسس والمظلة والكل الفاسكوليتشرز وفي الاخر خالص بتتحول ل sacs of air and maybe rupture. Also recurrent bacterial pyelonephritis and then atrophic kidneys and end-stage renal disease. End-stage renal disease. If both kidneys are affected, the patient have a single kidney, the patient will end by end-stage renal disease. Chronic pyelonephritis is the same, but it is considered as an persistent acute episodes or recurrent episodes. يبقى definition: consequence of recurrent or persistent acute pyelonephritis mainly occur in the presence of urinary tract obstruction or genitourinary abnormalities like vesicoureteric reflux and neurogenic bladder or stones. Clinically بيبقى في have an non-specific constitutional symptoms less severe than acute, with flank pain or abdominal pain also less in severity. Diagnosis: اليورين analysis هلاقي طبعا في بايوريا، في mild to moderate proteinuria، في white blood cell cast، والإيميجينج هيعمل scarring وclubbed renal calcisis، والتريتمنت بتاعها according للكوز and good antibiotic. This figures or this table to differentiate the choice of treatment in two most important cases like cystitis and pyelonephritis, and how to choose the empirical treatment before cultures and sensitivity. Okay? فالcystitis بنبدأ بالسلفا, start by sulfa or trimethoprim. The second line is cephalosporins or quininols. In pregnant women but without any renal impairment, you can start by nitrofurantoin or cephalosporin for the first 7 days. But in pyelonephritis, it is firstly start, first line is quininols with or without trimethoprim for 14 days. Then the second line, if no improvement or persistently fever, continue another 2 weeks by cephalosporin IV, and for another 2 weeks by oral cephalosporin if there is no response. In pregnant women, start from the first line by cephalosporin. Is the third cephalosporin, third or fourth, not first or second generation, third or fourth. It could be a pyelonephritis, there is a relapse, there is a reinfection. Relapse means that the same condition by the same organism. But reinfection, the condition started by another or affected by another organism or different organism. The second one, we finished pyelonephritis. Cystitis, pyelonephritis. The third is perinephric abscess. Perinephric abscess. Most commonly due to a local spread infection, patient have acute pyelonephritis or hematogenous spread from any site. يبقى peripheral abscess mostly caused by local spread من infection من patient have an acute pyelonephritis or hematogenous spread in elsewhere. Also, what is the most common organisms is Escherichia coli, then Klebsiella pneumoniae, then Candidial infection, specifically immune compromised. If there is a risk factor, yes, risk factors. Metabolic diabetes or any diseases cause immune suppression, or any drugs cause immune suppression زي corticosteroid or immunotherapy. وجود الobstruction, الstones, الvesiculoenteric reflux, ان الانفكشن repeated infection specifically in females, specifically in pregnant females, iatrogenic post-transplant because of immune suppression, drug used, or any indwelling surgery in urinary tract system. Clinically, there is a constitutional symptoms and mainly have a dysuria and other symptoms of lower urinary tract with severe palpable flank mass. Severe, tender, palpable flank mass. Lab, كل الانفلاماتوري criteria will increase. White blood cells, leukocytosis, C-reactive protein, ESR. Okay? Renal function could be normal or not according to the stage with positive blood culture. لازم يبقى في positive blood culture. Urine analysis, biuria, definitely. Bacteriuria, definitely. Positive nitrate, definitely. Positive leukocyte stress, definitely. And positive urine culture. Imaging exclude other congenital or causative risk, like stones, like vesiculoenteric reflux, ماشي. But definite diagnosis is the scarring of tubules or for يعني نشوف ان هو البلفس كله kidneys and peritoneum as an initial screening first of all. If there is a fibrosis, if there is a slipping, if there is a scarring, if there is, so that is an emergency. A treatment surgical must be trained. Okay, drainage by surgeon, and treat the pathological or anatomical abnormality. Remove the stone, correct the vesiculoenteric junction, and so on. With antibiotic, with good antibiotic according to the culture. خلاص؟ Finish? Interstitial kidney disease. The second topic. What time is it now?
10:05.
Have an hour and finish. Okay? Interstitial nephritis, there is two types, acute or chronic. Acute could be named allergic interstitial nephritis, mostly caused by drug-induced, and characteristically have an eosinophilia in blood. Okay? يبقى acute interstitial nephritis mainly drug-induced. Characteristically in blood we found a eosinophilia. Most of common drugs you know is a causative agent. All antibiotics, all non-steroidal anti-inflammatory, and even diuretics اللي احنا بنستخدمها in treatment of AKI. Okay? Infections, bacterial infections, all bacterial infections, all viral infections, all fungal infections, all كله can cause interstitial nephritis. Any autoimmune disorders like connective or collagen diseases, systemic lupus, rheumatoid, anti-basement membrane glomerulonephritis, all causes could be ending by acute interstitial nephritis. So, good definition is drug-induced, non-drug-induced, inflammatory produced, non-inflammatory produced, immune-mediated, non-immune mediated. Okay? This is better for classification. Clinically, interstitial nephritis بيجي بتوكسيميا, fever, وسكين rashes due to drugs. ماشي? Specifically has an eosinophilia. And most of cases presented by acute kidney injury. Acute kidney injury. اليورين analysis contain eosinophils. يبقى في eosinophiluria. Plus or minus white blood cells or RBCs. Urinary proteins mild to moderate proteinuria. يعني there is an active sediment. في proteinuria, في hematuria, في pyuria, but mainly eosinophiluria. وفي البلاد eosinophilia for diagnosis. Renal function could be associated with acute kidney injury. Renal biopsy ممكن نلاقي فيه white blood cell infiltration, but we don't have to proceed for renal biopsy. يعني in acute stage we not do renal biopsy. But in chronic without obvious or undetermined cause, we must to do renal biopsy. This is the pictures. Chronic inflammatory cells in interstitium, whole interstitium of the kidney have an inflammatory cells. Typical history بيجي عبارة عن drug hypersensitivity أو recent infection with sudden onset of fever, variable raising في الكيمستري renal يعني كرياتينين and urea وفراكشنيتد sodium. بالimaging الكدنey size will be normal or not, plus or minus active sediment hematuria or proteinuria, presence of white blood cells or في urine if it is infection, eosinophils if it is non-infection. التريتمنت discontinuation للcausative drugs, treat الانفكشن لو في ادي steroid, give steroid or immunosuppression. الكرونيك بقى يا اما a passing process from acute interstitial not well treated and continue لحد بيت a chronic, or have a multiple causes also, metabolic disorders, كل drugs and toxins, hematological, hereditary, ومostly الكرونيك interstitial ليها genetic backgrounds اللي هي mitochondrial mutations. Not all patients have acquired acute interstitial nephritis got chronic interstitial nephritis. Except in genetically predisposed patients اللي هو بيبقى فيه mitochondrial mutations. Autoimmune disorders, infection, obstruction, miscellaneous. Clinically بيجي دايما ب end stage renal failure. Kidney injury with increased في اليوريا والكرياتينين, active sediment hematuria وبتاع non-specific symptoms like uremia. Like patient with uremia, anemia, also وبيبقى معاهم renal impairment. اليورين analysis like uremia fixed specific gravity 10 by 10 ماشي. والرينال فانكشن بنلاقي فيه ريزد كرياتينين واليوريا. الصوديوم والبوتاسيوم بيبقى فيه الكترولايت ديستربنسز. والكالسيوم والفوسفات والالبومين also بيبقى فيه بتاع. الايميجينج is not mandatory. البلاد كالتشرز والالكتروفوريسيس to search for the cause، نعرف الكوز بتاع الكرونستي. و ending by ان بيبقى فيه atrophic scars والريجولار كورتيكال كونتور وبابيلاري نيكروزس. This is quite specific for analgesic nephropathy if it is caused by drugs. Renal biopsy is mandatory if there is no obvious cause. Renal biopsy. And then thank you.
كان عندي سؤال في الكومبليكيشن بتاعت الاول خالص لما كنا بنتكلم هو كومبليكيتد الميل 6 بريدسبوزنج اكتر للكومبليكيشن. هل الميل 6 اكتر انه يبقى كومبليكيتد اكتر من الفيميل مع ان الفيميل بيبقى الريكرنس عندها اعلى؟
لان الميل مور برون انه يحصل له انفكشن من البروستاتايتس من اليوريثرايتس السكشوال انتركورس وات ايفر كان نوعه ايه يعني او ازاي. غير الفيميلز بتبقى more prone if she's pregnant. If she's pregnant because hormonal disturbances, because the effect of pregnancy, الاميونيتي بتاعتها بتقل نتيجة البريجنانسي. need for good يعني dietation, vitamins, multivitamins and so on. Okay. الانفكشن by pregnancy itself. فعشان كده لكن هو الميل predisposed specifically old age due to presence of prostatitis أو prostate. والهاي ريت أو الهاي ريسك of stone in male more than female. stone passes male more than female. حاجة تانية؟
برضه كان في سؤال في الانترستيشال نفرايتس. الانترستيشال هل نقدر نعتبره هايبر سنسيتيفيتي رياكشن بسبب الايزونوفيليا اللي فيه؟
Yes. definition hypersensitivity reaction لأنه mainly caused by drug induced. So eosinophilia تساوي drug induced. Absence of eosinophils
It could be infection.
It could be other cause. But eosinophilia with eosinophiluria drug induced hypersensitivity reaction.
Interesting.